Hello and welcome to the second episode on fluid and electrolyte therapy in a surgical patient. We will talk on commonly used intravenous fluid and electrolyte homeostasis. Intravenous fluid are broadly classified into two: crystalloids and colloids. Crystalloids, they are clear aqueous solutions of low molecular weights. They are essential solutions of electrolytes in water. Examples of crystalloids are normal saline, Ringer's lactate, dextrosaline. Crystalloids pass freely from the intravascular to the interstitial space. Colloids, on the other hand, are solutions of large molecular weight which tends to remain in the intravascular compartment. Examples of colloids include the gelatin, heter starch, dextrans 40, dextrans 70. They are plasma expanders and they exert osmotic pressure which draws fluid from the interstitial compartment into the intravascular compartment. The crystalloid-colloid ratio is 3:1. This means that the volume expansion provided by three portions or three folds of crystalloids will be provided by only one portion of colloid, and crystalloids freely leak out of the intravascular space, leaving only 20 to 30% of the portion administered within this space in an hour. The common intravenous solutions. The commonly used intravenous solutions and their constituents in a liter: normal saline. 1 liter of normal saline, or 0.9% saline, contains 154 millimoles of sodium, 154 millimoles of chloride, and it has osmolality of 308 milliosmoles. Ringer's lactate. Ringer's lactate is more physiologic crystalloid. Its constituents are similar to those of the plasma. It contains sodium 130 millimoles, potassium 4 millimoles, calcium 4 millimoles, chloride 111 millimoles, and bicarbonate 27 millimoles. It has osmolality of 273 milliosmoles. Full strength Darrows. Full strength Darrows contain sodium 124 millimoles, potassium 36 millimoles, chloride 104 millimoles, bicarbonate 56 millimoles, and it has osmolality of 320 millimoles. Darrow's solution contain high amount of potassium, 36 millimoles for full strength Darrows and 18 millimoles for half strength Darrows. Pediatric saline, or 4.3% dextrose in 1/5 saline. It contains sodium 30.8 millimoles, chloride 30.8 millimoles in 1 liter of water, with glucose 43 grams, and it has osmolality of 300 milliosmoles in a liter. 5% dextrose water contain 50 grams of glucose in a liter of water. and it has osmolality of 320 milliosmol per liter. Electrolytes balance. Sodium output in the tropics. The total sodium output in the tropics is about 130 to 140 millimoles in 24 hours, and this is gotten from the total amount of sodium lost in 24 hours. Urinary loss of sodium is 114 millimoles in the tropics. In the sweat, about 10 to 16 millimoles, and feces 10 millimoles. This makes up a total of 130 to 140 millimoles loss in 24 hours in the tropics. For potassium, normal potassium outputs in the urine, 50 millimoles is lost. In the sweat, it is negligible. In feces, it's 10 millimoles, making a total of 60 millimoles in 24 hours. The summary of daily fluid and electrolyte requirements in a surgical patient are: water, 3 liters is required in 24 hours. Sodium, 130 millimoles, and potassium, 50 millimoles, with 100 grams of carbohydrate. After correction of deficits in a surgical patient, and patient is making adequate urine, pulse rate, blood pressure, central venous pressure all within normal limits, patient is placed on daily maintenance fluid of 1 liter 8 hourly in form of 2 liters of dextrose water, 5% dextrose water, and a liter of normal saline. 3 grams of potassium chloride is added to the fluid. However, ongoing loss is taken into consideration and added to the total maintenance fluid. Since the patient is on NPO, the glucose store in the liver is used up in the first 24 hours of starvation, and the body resorts to gluconeogenesis. If about 100 grams of exogenous glucose is provided, gluconeogenesis is minimized and acidosis is prevented. Fluid overload. Parenteral administration of fluid with ECF expansion, especially saline containing fluid, beyond the kidney can handle, can result to fluid overload. This condition is seen commonly in patients with hypoproteinemia, patients with renal failure, patients with hepatic diseases and congestive cardiac failure. There is subsequent movement of this fluid into the interstitial space, leading to interstitial edema. The fluid overload presents with distended neck veins. There is weight gain, pedal edema, features of circulatory overload, which include tachycardia, hypertension, pulmonary edema with crepitations. The central venous pressure is greater than 15 millimeters of mercury. Features of cerebral edema will manifest. This includes headache, vomiting, confusion, restlessness, convulsion, and coma. Gastrointestinal symptoms in patients with fluid overload include prolonged postoperative ileus,